Hello everyone, I am Docsaab and today we are going to dive into a critical topic in global health, enteric fever, more commonly known as typhoid fever. As someone deeply interested in medical education and clinical knowledge, I believe understanding this disease is not just academically important but vital for patient care, especially given its significant impact worldwide. This presentation aims to provide a comprehensive overview from its origin to its prevention strategies, drawing directly from the latest information. Let's begin with an introduction to enteric fever. This is a severe systemic bacterial infection, and our primary focus today will be on the form caused by a Salmonella enterica serover typhi or S. typhi. It is a life threatening disease that poses a significant global public health challenge, particularly prevalent in regions with inadequate sanitation and limited access to safe drinking water. The numbers are quite stark. Global incidence rates indicate an estimated 11 to 20 million cases and a heartbreaking 1,28,000 to 1,61,000 deaths annually. In specific geographic areas like South and Southeast Asia, enteric fever is actually the leading cause of community acquired bloodstream infections. It is also a reportable disease in many developed nations, second only to malaria as a cause of severe infection in travelers. Factors like urbanization and climate change are further exacerbating the global burden of the disease. Now, let's explore the fundamental cause and the condition that favor its spread. The causative agent, as mentioned, is the bacterium Salmonella enterica serover typhi. This is not just any bacterium, it is a gram-negative, rod-shaped, motile, non-spore forming bacillus. It has a remarkable ability to survive in oxygen-rich environments, including sewage and water, which is critical to its transmission. A key point to remember is that humans are the only natural host for S. typhi. It lives exclusively in their intestinal tract and bloodstream. This unique host specificity underpins many of our prevention strategies. Several factors significantly increase the risk of infection. These include poor sanitation, a foundational issue in many endemic regions. Closely linked is a contaminated water supply, which act as a major vehicle for the bacteria. Inadequate hand hygiene, particularly after using the toilet or before preparing food, facilitate person to person spread. Lastly, the existence of a chronic carrier state in food handlers poses a particularly insidious risk as seemingly healthy individuals can continuously share the bacteria, unknowingly contaminating food destined for a consumption. Understanding how S. typhi spread is a crucial for breaking the chain of infection. The primary mode is oral transmission, often occurring when food or beverages are handled by an individual who is an asymptomatic carrier. These carriers chronically share the bacteria through their stool and less commonly their urine. A very common and often overlooked route is hand to mouth transmission, which happens after an individual uses a contaminated toilet and neglects proper hand hygiene. In many developing parts of the world, a significant pathway is oral transmission via sewage contaminated water or a shellfish. It is also worth noting, though rare, that sexual transmission has been documented among men who have sex with men. An important ecological aspect is that S. typhi and S. paratyphi can persist in environment for extended periods in non-culturable, non-replicative state. This creates a persistent environmental reservoir which can lead to continued infection and outbreaks, for example, through contaminated crops. Let's meticulously trace the journey of S. typhi once it enters the human body, detailing its sophisticated pathogenic mechanisms. The process begins with ingestion. One swallow, the bacteria face the acidic environment of the stomach. They possess a crucial virulence factor, the VI capsule, which helps them resist gastric acid and survives this harsh environment, allowing them to reach the small intestine. Next is intestinal invasion. Upon reaching the ileum, S. typhi specifically targets and invades the M cells of pear patches. Following this invasion, the bacteria are phagocytes by macrophages, but remarkably they survive and multiply within these immune cells, using them as a shield and a means of transport. This leads to lymphatic and hematogenious spread. From the Peyer's patches, the infected macrophages transport the bacteria to the mesenteric lymph nodes. From there, they enter the thoracic duct and subsequently the bloodstream, causing the initial phase of infection known as primary bacteremia, which typically occurs during the first week. Following primary bacteremia, the bacteria disseminate and colonize various organs rich in reticuloendothelial cells, including the liver, spleen, bone marrow, and gallbladder. They continue to multiply within the macrophages in these organs, leading to a sustained release of bacteria into the bloodstream, which is termed secondary bacteremia. This phase is clinically significant as it is associated with characteristic persistent high fever. Finally, a crucial step involves intestinal reinfection. The bacteria are excreted from the liver into the bile and re enter the intestine. This re-entry causes further inflammation, necrosis, and characteristic ulceration of the Peyer's patches. These ulcers are typically oval with their long axis running parallel to the ileum, which distinguishes them from the other types of intestinal ulcers. This detailed understanding of pathophysiology helps us appreciate the systemic nature of typhoid fever and its potential for severe complications. The incubation period for typhoid fever typically ranges from 6 to 30 days, although it most commonly falls between 9 to 14 days. This variability is influenced by several factors, including the infective dose, the virulence of the bacterial strain, the route of infection, and the host immune status. Now, let's turn our attention to the timeline of the disease. What's important to note is that the onset of typhoid fever is generally gradual. It can present initially as mild illness with a low grade fever, but it has the potential to progress to a severe disease accompanied by a abdominal discomfort and multiple complications if left untreated. To help us understand this progression, the classical clinical stages are often described week by week. Let's break down the clinical presentation by week, which is crucial for early recognition. In the first week, roughly days 1 to 7, the symptoms begin somewhat insidiously. The most prominent feature is a fever that gradually rises in a stepwise fashion, starting low grade and progressively increasing, potentially reaching high temperature of 39 to 40 degrees Celsius. Patient commonly experiences constitutional symptoms such as malaise, a frequent headache, fatigue, and general weakness. A non-productive cough is also common respiratory symptom. Regarding gastrointestinal complaints, constipation is more common than diarrhea in adults during these initial stages, along with anorexia. Other notable signs include relative bradycardia, which is slow heart rate relative to degree of fever, and epistaxis or nosebleeds occurring in about 25% of cases. Hematologically, we might observe leukopenia, eosinopenia, and relative lymphocytosis. As we transition into the second week, days 8 to 14, the disease typically intensifies. The fever becomes persistently high, often plateauing at 40 degrees Celsius. Gastrointestinal symptoms evolve. Abdominal pain becomes more pronounced, often described as generalized or located in the right lower quadrant. Diarrhea may become more prominent, especially in children, though adults might still struggle with constipation. A classic, though not universally present, skin manifestation is the appearance of roach spots. These are macular erythematous lesions, 2 to 4 mm in diameter, that fed on pressure and appear on trunk in approximately 25 to 33% of light skin patients. They are transient and blanchable. Organomegaly is common with both splenomegaly and hepatomegaly, often accompanied by elevated liver transaminases. Finally, neurological changes may begin to appear, manifesting as mild delirium or altered mental status. By the third week, days 15 to 21, the fever remains very high, often with minimal daily oscillation. Patient experience severe prostration, dehydration, and malnutrition. Neurological symptoms become much more pronounced. These can include significant delirium, confusion, stupor, or the characteristic smuttering delirium or coma vigil, a state of semi consciousness marked by low grade mumbling and aimless movements. Encephalopathy may also develop. Gastrointestinal distress intensifies with severe abdominal distension and worsening pain. Into the fourth week, days 22 to 28 and beyond, the patient's course diverges. If untreated, the patient either gradually improves with the fever slowly subsiding or tragically succumbs to the severe complications of the disease. It is important to be aware of the potential setbacks. Relapses occur in 15 to 20% of cases, which can happen within days or weeks of apparent recovery. These relapses are typically milder in their symptoms and are attributed to residual bacteria reactivating. Furthermore, some individuals, particularly those with pre existing conditions like gallstones, may enter a chronic carrier state. They asymptomatically shed STIFE in their feces for months or even years, posing a continuous risk of transmission to others. Typhoid fever is not just a febrile illness, it carries a significant risk of severe and potentially life threatening complications. One of the major complications is intestinal hemorrhage occurring in about 5 to 10% of cases. This happens due to the erosion of blood vessels within the inflamed and necrotic pure patches. While serious, it is often not immediately fatal unless the bleeding is massive. Even more critical is intestinal perforation, which occurs in 1 to 3% of cases and is often considered the most critical and frequently fatal complication. This results from full thickness necrosis of the intestinal wall, typically in the distal ileum or proximal colon, caused by bacterial proliferation and the host immune response. When the wall perforates, intestinal contents leak into the peritoneal cavity, leading rapidly to peritonitis and septic shock. These can occur without clear warning signs until sepsis sets in, characterized by acute severe abdominal pain, rigidity, and rapid deterioration. Another significant complication is encephalopathy, which results from severe systemic inflammation, direct effects of bacterial toxins on the brain, and metabolic disturbances. Beyond this, a range of other complications can manifest, including acute cholecystitis, hepatitis, pneumonia, acute bronchitis, myocarditis, renal failure, meningitis, osteomyelitis, and the formation of abscesses in various organs. The breadth of these complications underscores the importance of prompt diagnosis and treatment. Accurate and timely diagnosis of typhoid fever is absolutely crucial for effective treatment and preventing these severe complications. However, this is often a significant challenge. The non-specific nature of its symptoms frequently mimics other febrile illnesses, making clinical differentiation difficult. In many resource-limited settings, diagnosis is often empirical due to lack of diagnostic tools. Let's examine the diagnostic methods. The gold standard is blood culture. This involves incubating a blood sample to allow S. typhi to grow, followed by isolation and identification. Its sensitivity, however, varies significantly, ranging from 40 to 80% during the first week and decreasing thereafter, especially with prior antibiotic use. Results typically take 2 to 5 days, which can delay targeted treatment. It also requires specialized equipment and personnel. Bone marrow culture is considered the most sensitive diagnostic method, over 90% particularly useful in patients who have already received antibiotics as bacteria persist longer in bone marrow. However, it is highly invasive and painful, making it impractical for routine use. Stool culture involves isolating S. typhi from fecal samples. Its sensitivity is low in early stages due to intermittent bacterial shedding, but it increases in later stages and is crucial for identifying chronic carriers. Similar to blood culture, results take days. Urine culture has a low sensitivity, typically less than 10%, and is generally not considered a primary diagnostic method. For a serological test, the Vidal test detects host antibodies, agglutinins O and H, against S. typhi antigens. Despite its wide use due to low cost and ease, it has significant drawbacks. Low sensitivity and specificity, especially in endemic regions due to cross reactivity, previous exposure, or a vaccination. Antibodies may not be detectable in early stages, false negatives, and titers can persist after infection. It cannot distinguish between current, past infection, or vaccine response. Despite its limitations, the Vidal test is still widely used in resource limited settings due to its low cost and ease of performance, although its diagnostic capacity has a significant drawbacks. Rapid diagnostic tests such as Typhidot or Tubex TF are a lateral flow assays detecting specific IgM and IgG antibodies or bacterial antigens. A Cochrane review indicated that no RDT achieved balance accuracy above 85% with sensitivity typically 60 to 90% and specificity 80 to 95%. They also have limitation with false positives and negatives. Finally, molecular methods, primarily PCR, directly detect S-typhoid DNA in clinical samples. While highly sensitive and allowing for quantification of bacterial load, they require expensive equipment, specialized reagents, and highly trained personnel, limiting their widespread use in resource poor settings. There is also high risk of false positive due to environmental DNA contamination if not handled carefully. The cornerstone of typhoid fever treatment is prompt and appropriate antibiotic administration coupled with comprehensive supportive care. However, treating typhoid has become increasingly complex due to the global emergence and spread of antibiotic resistant S type strains. Therefore, the choice of antibiotic is critical and must be guided by antimicrobial susceptibility testing. Whenever possible, taking into account local resistance patterns, disease severity, patient age, and prior treatment history. Supportive care is also vital and includes adequate rest, oral and intravenous fluids, and electrolytes to manage dehydration, nutritional support, and antipyretics like paracetamol for fever management. For uncomplicated cases, non-MDR and non-XDR, historically ampicillin, chloramphenicol, and trimethoprim sulfamethoxazole means quatrimoxazole were effective. However, the widespread emergence of multi-drug resistance since the 1970s has rendered this largely ineffective in many endemic areas. Fluoroquinolones such as ciprofloxacin and ofloxacin were formerly considered the drugs of choice for adults. A typical ciprofloxacin dose for adult is 500 mg orally twice daily for 5 to 7 days. Their use in children is generally restricted due to concerns about cartilage damage, though benefits may outweigh risk in specific situations. For MDR cases, resistance to ampicillin, chloramphenicol, quatrimoxazole, and fluoroquinolone resistant cases, third generation cephalosporins are commonly used. Ceftriaxone intravenous is a key option for adults. A typical dosage is 1 to 2 gram intravenously once daily, with severe cases potentially requiring up to 4 gram once daily or 100 mg per kg up to 4 gram per day. For children 1 month and over less than 50 kg, the dosage is 50 to 100 mg per kg, maximum 4 gram once daily. The duration is typically 7 to 14 days. Then cefixime oral can be an option for milder cases or as step-down therapy after IV ceftriaxone, typically 10 to 15 mg per kg per day orally in two divided doses for 10 to 14 days. Azithromycin is also effective for adults. A typical dosage is 500 mg orally once daily for 7 days. For children, it's 10 to 20 mg per kg orally once daily for 5 to 7 days. For extensively drug resistance XDR typhoid, XDRS type strains are resistant to first line drugs, fluoroquinolones, and third generation cephalosporins, posing a severe public health threat, notably spreading from Pakistan. Carbapenems such as meropenem and imipenem are currently considered the last line of defense. For meropenem intravenous in adults with complicated infections, 1 gram intravenously every 8 hours is a common with doses adjusted based on severity. For XDR typhoid, for children, doses is evaluated in studies for monotherapy versus combination therapy with azithromycin. Duration is typically 10 to 14 days or longer for severe cases. Finally, let's discuss prevention, which is paramount given the challenges in treatment. Preventive measures for typhoid fever focus on multi-pronged approach encompassing vaccination, improved sanitation, and strict hygiene practices. Vaccination is highly effective tool, particularly for individuals traveling to or living in endemic areas. The World Health Organization recommended several types of typhoid vaccines. Live oral TY21A vaccine, example is Vivotif, administered orally in 3 or 4 doses over a week, depending on the manufacturer. A booster dose is recommended every 5 years for continued protection. Immunization should be completed at least 1 week before the expected exposure. Parenteral VI polysaccharide vaccine, Typhim VI or Typhirix, administered as a single intramuscular injection and approved for individuals aged 2 years and older. A booster is recommended every 3 years if ongoing exposure risk persists. Then conjugated VI polysaccharide vaccines. These are newer vaccines like Type Bar TCV or Typhoidfever, which offer long-term immunity and are particularly effective against antimicrobial resistant typhoid. They have been used in vaccination campaigns for children in affected urban areas to combat drug-resistant typhoid and are approved for children as young as 6 months. A single dose of Type Bar TCV has shown lasting efficacy for over 4 years in children aged 9 months and older. Beyond the vaccination, water, sanitation, and hygiene improvements are critical, as S. typhi is primarily transmitted through fecally contaminated water or food. This means ensuring access to safe and treated drinking water, which can involve water treatment or filtration. Proper installation and management of toilets and sanitation systems are essential to prevent the spread of bacteria from fecal matter, with public and private facilities needing to maintain proper sanitation. Hygiene practices are fundamental. Thorough hand washing with soap and water is a crucial, especially before eating or preparing food, after using the toilet, and after changing diapers. Basic hygiene is strongly associated with lower odds of typhoid. Food safety involves protecting food meant to be eaten raw from contamination and washing it thoroughly, as well as boiling or treating food and beverages. Lastly, feces must be disposed of in sanitary manner. By combining these strategies, we can significantly reduce the burden of enteric fever. In conclusion, we have explored the enteric fever or typhoid as a significant global health challenge caused by Salmonella typhi. This gram-negative bacterium, exclusive to human host, spreads primarily through contaminated food and water, exacerbated by poor sanitation and inadequate hygiene. We have seen how its pathophysiology involves a complex journey through the body, leading to a multi-stage clinical presentation and potentially severe complications like intestinal hemorrhage and perforation. While diagnosis can be challenging, relying on culture methods and facing limitation with serological test, treatment hinges on appropriate antibiotics, constantly challenged by increasing drug resistance. Ultimately, effective prevention through comprehensive vaccination programs and robust water, sanitation, hygiene, or wash initiatives remains our strongest defense against this debilitating disease. Thank you so much, guys. Please like, share, and subscribe to the Docsaab's Diary.